So I'll be briefly talking about ARDS phenotypes. If you look at the Berlin definitions, these were a modification from AECC definitions earlier. So all of us know, and if you look at the oxygenation part, there has been some attempt to sort of classify or separate them into mild, moderate, and severe categories. And we are familiar with the risk factors associated with ARDS. So direct lung injury, the most common causes which various studies have revealed: pneumonia, aspiration, pulmonary contusion, near drowning, etc. And indirect, the major causes include sepsis, multiple trauma, acute pancreatitis, transfusion related, etc. So when we look at the therapeutic options, now this is mild, moderate, severe ARDS. This is the PF ratio. So we understand that low tidal volume of protective lung ventilation will be the common baseline strategy. And for moderate to severe ARDS, we would obviously be using higher levels of PEEP. And we can give a trial of an IV in very mild ARDS. And patients who are critical, moderate to severe ARDS, we would like to use neuromuscular blocker for initial 48 hours to avoid any desynchrony and frequent recruitment and de-recruitment of the alveoli. And of course, then if nothing is helping and our oxygenation targets are not being met, then we would prone them and go for prone ventilation. And lastly, if nothing is helping, then as a rescue measure, we'll be going to use the ECMO. So this information we have, and if you look at one of the largest observational studies that was done globally, Lung Safe study, they found that ARDS prevalence was 10.4%, and 23.4% of all patients who were ventilated in ICUs fulfilled the ARDS criteria. The unfortunate part is there is no single diagnostic test. There is ARDS is still under-recognized by 50% of the physicians, and death is still ranging from 35 to 46% in severe ARDS. So despite randomized control trials showing a consistent decrease, but in the clinical setting, we find that there is a significant mortality associated with severe ARDS. So these deaths that we see, because in patients with severe ARDS, have an association with ARDS, but ARDS per se may not be the direct and sole cause of mortality, because eventually they go into multi-organ failure. So some of the therapy that has been tried is, this is a synopsis, lung protective ventilation strategy, strong recommendation, high level of PEEP, moderate severe ARDS, conditional recommendation, lung recruitment conditional, prone positioning, strong recommendation, HFOV, strong recommendation against its use, ECMO rescue therapy. Then we have conservative fluid management, then pharmacological, glucocorticoids, inhaled nitric oxide, neuromuscular blockade, etc., etc. So all with the conflicting data. Some other therapies that have been suggested is NIV recommended for early phase of respiratory failure, tracheostomy for prolonged mechanical ventilation, P-plat less than 30 recommended for all patients, low tidal volume for all patients, driving pressure less than 15 for all patients, high PEEP strategy only for moderate to severe. Prone position, the recommendation as per the trial was less than 150 PF ratio. Neuromuscular blocking agents are also recommended in first 48 hours. Then ECMO is, like I said, rescue. Glucocorticoids, again, no responsive phenotype have been identified. That means there have been attempts to further subdivide ARDS so that we understand which therapy would be effective in what group of patients. So people have looked at biomarkers also to look at personalized medicine customized for that patient's need. So what we know is this cartoon depicts that this is a healthy alveolus. The interstitium is also healthy and the capillary endothelium is also healthy. Exudative phase, you have macrophages, neutrophils coming into play, and there is interstitial flooding, and there is endothelial barrier destruction, migration of neutrophils, and a DIC. Proliferative phase, again, there's significant damage that you can see in the alveoli, fluid filled here. Again, proliferation of interstitial fibroblast is occurring and endothelial proliferation is occurring. And finally, the fibrotic phase, there is interstitial and intraalveolar fibrosis, with obliteration of the microcapillaries. And if, as we have seen in COVID in some of the patients, this may lead to permanent disfigurement in the lung architecture. So what are the various biomarkers? In the exudative phase, we have angiotensin 1, 2, 1 milligram factor, endothelins. Alveolar cell damage is caused by RAGE, IL-33, TSLP, so on and so forth. So these are the biomarkers that are implicated here. Then inflammatory cells, cytokines, chemokines, IL-1 beta, IL-6, IL-18, TNF-alpha, etc. And complement, coagulation pathways and fibrinolysis cascades, they all become active here. Fibroproliferative phase, again, endothelial apoptosis, proliferation occurs, epithelial alveolar cells apoptosis and proliferation occurs. Similarly, myo and fibroblast proliferation occurs. So to summarize the biomarkers of ARDS, epithelial damage is caused by all these biomarkers, starting from RAGE to KGF. Endothelial damage is caused by angiotensin 1, 2, 1 milligram factor, etc. Inflammatory, we have pro-inflammatory and anti-inflammatory. We know that concept very well. Anti-inflammatory, the major being IL-10, and pro-inflammatory major being IL-6, TNF-alpha. And then we have coagulation fibrinolytic agents, also biomarkers also. So what do the biomarkers tell us? Well, ARDS, despite this knowledge, it continues to be a syndrome associated with high mortality. Main treatment relies on correct strategic use of mechanical ventilation to protect the lung, and we want to avoid pro-inflammatory mechanism triggered by mechanical ventilation. But it does not represent real treatment of ARDS, because mechanical ventilation per se cannot be the treatment. It's just an organ support. And so we need to know more. So therapy of ARDS should probably be based on inflammatory mechanisms responsible for lung injury, possibly taking into account genetic difference between patients, origin of ARDS, whether it is primary or secondary ARDS. So that's how the concept of ARDS phenotype appeared. And if we look at the lung safe, the study found higher airway pressure, PEEP, PIP, driving pressure, lower PEEP and high respiratory rate were associated with high mortality, along with old age, active neoplasm, and chronic liver disease. As ARDS is a heterogeneous disease, it's very difficult to predict which therapies would be suitable or counterproductive in a particular patient. And the researchers have been trying to identify ARDS subsets where specific targeted customized therapies may be applied to improve the clinical outcome. Now, it is also believed that identification of phenotype which would respond differently to different intervention is important, because otherwise we are stuck up at 35 to 45% mortality with nothing much to offer. So we do not know much whether it would be based on the PF ratio or biological variables or biomarkers to identify specific phenotype. There is a signal from some of the recent studies that I'll discuss about the presence of different phenotypes. And possibly it is showing us a ray of hope that there could be heralding of an era of personalized therapy in ARDS. So let's see. This was a classic paper by Calfee and her group, subphenotypes in acute respiratory distress syndrome. So they did latent class analysis of data from 2 randomized controlled trials. So what they are saying is, why can't we identify subphenotypes like we do in asthma, breast cancer, etc., and other diseases? So they looked at the previously done study. So LCA was used, which identified subgroup of patients having similar variables of baseline. They didn't look at the outcome. So they would, subsequently see that. So then they looked at the association of phenotypes with clinical outcome in both the groups, and response to PEEP in the alveoli cohort was also tested. So this was a proof of concept study. They also used biomarkers from 1022 patients recruited in ARMA alveoli trial, and they applied latent class modeling. So they could identify 2 different subphenotypes of ARDS. They also looked at 8 biomarkers in both trial groups, including surfactant protein D, 1 milligram factor antigen, soluble intracellular adhesion molecule 1, IL-6, IL-8, soluble tumor necrosis factor, receptor 1, plasminogen activator inhibitor, PAI1, protein C. So when they looked at the ARMA and alveoli subset of patients, they found that there was one group that they labeled as a hyperinflammatory phenotype 1, and the other group was hyperinflammatory, which they call phenotype 2. Then they looked at the clinical outcome. So what did they find? In the hyperinflammatory, that is phenotype 2, they found there was higher plasma concentration of subphenotype, higher plasma concentration of inflammatory markers. So the biomarkers like IL-6, IL-8, etc. were high. There was higher prevalence of vasopressor use. There were lower serum bicarbonate and protein C concentration, and there was a higher prevalence of sepsis. These patients had a higher mortality and they had fewer ventilator-free days. So based on that, a prediction model was also made using 3 variables: IL-6, TNFR1, and vasopressin use, whether it was used or not. And the AUC for the phenotype prediction was quite accurate, 0.937 in ARMA and 0.929 in alveoli cohort, suggesting a high accuracy of prediction. Limitation included the use of data from previous trials, and no prospective new trials were done. So this is what they showed. So phenotype 2 was the, as you will remember, hyperinflammatory. 1 was hypoinflammatory. So you find the mortality is quite high. Ventilator-free days are much less, and organ-free days are also much less. And in alveoli also, you have a similar trend. Very high mortality in this phenotype 2. Less ventilator-free days, less organ failure-free days, which is all quite significant. And when they looked at the application of PEEP, so they found that with low PEEP, the mortality was high in this group, but with high PEEP, the mortality was less, although it did not reach statistically significant levels. Even ventilator-free days were more, organ-free days were more with the high PEEP in the phenotype 2. Also the mortality was in high PEEP group in phenotype 1 was higher. So this group probably is not the group where we would go for high PEEP. So this is some signal from the Calfee analysis. So they said that we have identified 2 subphenotypes within ARDS. One is categorized by more severe inflammation, shock, metabolic acidosis, by worse clinical outcomes. Response to treatment in a randomized trial of PEEP strategies differed on the basis of subphenotype. So if we can identify these phenotypes, it will be useful in at least, understanding these patients and using lower high PEEP. Then we had 2 more studies, HARP2 and SAIL studies. These were, RCTs. Basically, they looked at the hydromethyl CoA reductase inhibition by simvastatin, statin in acute lung injury to reduce the pulmonary dysfunction. SAILS was another trial which looked at statin for acutely injured lungs from sepsis. We know very well that statin trials in ARDS did not show any clinical benefit in terms of outcome or ventilator-free days. SAILS study even showed some detrimental effect on kidney and liver functions. But then when post-hoc analysis of these 2 studies were done, they identified 2 distinct phenotypes. Again, hypoinflammatory and hyperinflammatory. Hyperinflammatory had higher concentration of TFNR1, IL-6, platelet count, shock. More vasopressin was required, and they had more metabolic derangement. So when they looked at data this way by looking at the hyper and hypoinflammatory phenotypes, they found simvastatin improved mortality in the hyperinflammatory group. But rosuvastatin surprisingly did not have any effect. So we still do not know how to use this information or interpret this information. So MARS was another study, molecular diagnosis and risk stratification for sepsis. This was a Dutch study. They collected 20 biomarkers of all variety, and they did a cluster analysis to identify phenotype without looking at the clinical or outcome data. So they found 2 distinct phenotypes, uninflamed and reactive. Reactive ones had higher Apache 2 scores, Apache 4 scores. Indirect, they were mostly because of indirect ARDS. and they had significantly high mortality compared to uninflamed phenotype. So the reactive phenotype remained independently associated with ICU mortality after correction of Apache-4 or co-founders like PF ratio, pulmonary cause for ARDS. This difference in mortality was independent of Berlin classification for severity of ARDS. And they constructed another, ROC, and they found that the accuracy area under curve was 0.98, so highly accurate. So they could identify two distinct clusters with a high mortality in the reactive group. And this was, if the patient belonged to the high reactive phenotype, then this was independently associated with higher mortality. So another paper, again by Calfee and her group, looked at molecular phenotypes, direct versus indirect ARDS, single versus multi-center studies. So they looked at two cohorts: single center observational, 100 patients with ARDS severe sepsis, multi-center sample of patients of ARDS which were enrolled in FACT trial. You remember the fluid and CVP versus PA catheter trial. So they measured lung epithelium, endothelial injury, inflammation using plasma biomarkers. And as a secondary objectives, they looked at the prognostic value of these markers, whether it differed in direct versus indirect lung injury patients. So they used ELISA to measure the biomarkers. So they measured all these biomarkers, and they found that biomarkers of lung epithelial injury, RAGE, was significantly higher in direct ARDS than in indirect ARDS. Conversely, levels of angiotensin II, biomarker of endothelial injury, was significantly lower in direct ARDS than in indirect ARDS. And IL-6, IL-8 were found to be similar between the two groups. So this is again the same data. I'm skipping these slides in the interest of time. So when they looked at the FACT database, they said it's a single center. When the single center study, they found that IL-8, IL-6, RAGE, and Ang2 were all associated with significant increase in odds of death, but SPD was not associated with mortality. So these findings were replicated in the multi-center study. So direct ARDS is characterized by more severe lung epithelial injury compared with indirect ARDS, and indirect ARDS is characterized by more severe endothelial injury and inflammation. So that means the biomarker levels are important indicators in direct versus indirect patients. And from the earlier Calfee studies, we know that the biomarkers, if they are high, then we can use higher level of PEEP there. They are the serious patients where the mortality is high. So this was another paper where they looked at phenotypes of ARDS after major trauma, and these were acutely ill patients. So again, LC analysis was done, and they found they could identify early onset class 1 and late onset class 2. Early onset were older, more intense hemorrhagic shock, hypotension, severe thoracic trauma, and they had a high level of biomarkers, both RAGE as well as Ang2. But they could not find difference in mortality between class 1 and class 2. So another paper that looked at, this was published in the Blue Journal, looked at response to fluid therapy. So when from FACT trial, Calfee identified these two patients, the authors of this study hypothesized that these two phenotypes would respond differently to liberal and restrictive fluid strategies. They use 8 biomarkers, and they again use latent class modeling to identify phenotype 2, which was the reactive phenotype, where the biomarkers were high and there was lower serum bicarbonate, protein C, Ang2, and RAGE. So this reactive phenotype required vasopressors more frequently, had 40% mortality when restrictive fluid therapy was used, compared to 50% mortality when liberal fluid was used. The higher Ang2 levels found here represent more endothelial permeability. So in this phenotype, we know that less fluid is better. Restrictive fluid strategy is better. 10% less mortality as per this model. So this was also the response to treatment, high PEEP versus low PEEP, conservative versus liberal fluid management. So here you can see this is the uninflamed group, this is the reactive group. So reactive group with low PEEP, the mortality is higher. With high PEEP, the mortality is less. And when you look at the hospital mortality, again, in terms of the fluid use, liberal versus conservative, you find conservative mortality is less compared to liberal in the reactive group. So similarly, they showed a difference in the mortality. And finally, they concluded that it is possible to prospectively enroll patients in clinical trials by ARDS subphenotype. And if we do future trials by identifying a subphenotype and then studying the effect only in these patients, possibly we'll have better application of the more definite therapeutic applications for ARDS. So this was a very important editorial in the Blue Journal, where they said, what are the implications of this research going forward? The authors have shown unequivocally that there is an urgent need for further research to understand these ARDS subgroups within the complex phenotype-endotype continuum and to establish uniform reporting standards. Kalfi and colleagues have done excellent service to our specialty by highlighting a fresh approach to studying patient heterogeneity, which is likely to both improve our understanding of the pathophysiology of ARDS and inform future trials in ARDS as a new era of personalized medicine for ARDS will emerge. So another paper that looked at almost the similar things. I think I'll jump to the second part. So standard ARDS, we know there is non-cardiogenic pulmonary edema, shunt-related hypoxemia, reduced aerated lung size, baby lung, low respiratory compliance, and if we ventilate them, they end up with villi. If we allow them to breathe spontaneously, they have aggravation of the disease by SILI. So when you look at the early management of ARDS, this was a 2019 paper, and as you can see here, this is the protective lung ventilation strategy, and then you have, as the PF ratio goes down, you start going to higher PEEP, and then you start proning them and finally look at VV ECMO. So what is different in COVID-19 ARDS? Well, COVID ARDS patient characteristics show that there is dissociation between relatively well-preserved lung mechanics and the severity of hypoxemia. It is not uncommon to see happy hypoxia in COVID ARDS patients, which is silent hypoxia, no distress, good lung compliance, but for the doctor it is frightening, but patient is not feeling anything. So the reasons could be possible loss of lung perfusion regulation, hypoxic vasoconstriction. CT suggests remarkable hyperperfusion. COVID lungs are characterized by severe VQ mismatch, mild pulmonary hypertension and lung compliance, and a low pulmonary capillary pressure. And CT scan shows bilateral peripheral ground glass opacities with or without consolidation, rounded morphology, or visible intralobular lines. So CARDS primarily seem to affect the vasculature, which is the endothelium. Patient can retain relatively good compliance despite very poor oxygenation. Minute ventilation is characteristically high in these patients, and infiltrates are often limited initially to GGOs on CT, that signifies interstitial rather than alveolar edema. And then many patients do not appear overtly dyspneic and can be assigned to type L. So this was the, again, concept of phenotype. Type L means characterized by low lung elastance, means they have high compliance. They have lower lung weight as seen by CT and low response to PEEP. So again, the other phenotype that was identified or that's been proposed is type H, where we have extensive CT consolidation, high elastance or low compliance, higher lung weight, and high PEEP response. So the type L and H are conceptual extremes of a spectrum that includes intermediate stages where their characteristic may overlap. And another consistent feature is a highly activated coagulation cascade, which leads to widespread micro-macro thrombosis in the lung and other organs associated with very high serum D-dimer levels and poor adverse outcome. So CARDS lung fibrosis appears to be a very important long-term effect in some of the patients. 17% of patients in a study had fibrous stripes in the chest CT scan. And these fibrous lesions, they, once the healing starts, they may gradually, because of chronic inflammation, with gradual replacement of cellular components by scar tissue. So these may be permanent scars, permanent loss of, lung parenchyma, the active physiological lung parenchyma. So pulmonary thrombosis is identified by elevated D-dimer levels, diffuse microvascular thrombosis, thrombotic DIC, dilated pulmonary vessels on CT, and pleuritic pain. So what is happening here? There is disproportionate endothelial damage that disrupts pulmonary vasoregulation, promotes ventilation perfusion mismatch, and fosters thrombogenesis. And cilia and villi will both further add to the complications and will intensify the strain here. So that means we should pay more attention to the vascular side, avoid fluid overload. Reduction of cardiac output demands is also not a bad idea. Now, this is a very interesting CT angiogram in COVID patients. So what we see here is, this is a 42-year-old male, and he has low D-dimer, LD is low D-dimer, and low compliance group. So here, static compliance is 38. So here you see, this is how it looks. And when the patient, another patient, 62-year-old man, now he has high D-dimer, he has low compliance. So you can see the change. Static compliance has gone down, and D-dimer levels are high. PF ratio is significantly less here compared to 144 here. So high D-dimer indicates severe hypoxemia. Another patient's low D-dimer group, but again, here you have high compliance. So static compliance is 46, PF ratio 114. But another patient which belongs to high D-dimer, but the high compliance, now you see things are pretty bad. So D-dimer, whether it is low compliance or high compliance, is a bad thing. And you can see that here the PF ratio has come down to 76. So purple blue coloring indicates hyperperfusion. And you have evidence of significant, thromboembolic lesions in the vascular tree. So in terms of difference from usual ARDS, timing of we take ARDS, conventional ARDS less than 7 days. Here it could be 8 to 12 days. Respiratory system compliance may be normal in some of the patients, and severity would be the same. Management protocols, possibly HFNO we can use. As of now, we don't have answer to this. Timing of invasive ventilation is also very important. Corticosteroids are beneficial here in CARDS. They are, treatment modality that reduce mortality. Injury site are epithelial cells. And then if you look at PF ratio, it could be low in some patients of COVID-19. Dyspnea could be mild. HPV could be absent. VQ mismatch could be very severe. Pulmonary hypertension could be mild. Lung compliance could be mild. So people have suggested some algorithm here. So you are looking at a target of achieving SpO2 90 to 94%. If your FiO2 requirement is more than 0.4% and there is no ceiling of escalation, that means patient is not a DNI, DNR patient. Look at the shunt fraction, assess his work of breathing. If the work of breathing is high, you need to consider intubation mechanical ventilation. So they are very, very clear that if work of breathing is high, then we need to ventilate them. And in case the work of breathing is low, then we can look at HFNO or NIV. But again, if the saturation goes down, then we have to come back to this algorithm. And if there is no shock, low dose vasoconstrictors, minimal fluid, keep patient dry, observe organ for organ dysfunction. And if even with the high FiO2, your saturation goes down, then you can increase PEEP in steps of 2 centimeter up to 15 centimeter. Delta pressure should always be kept less than equal to 15. Consider neuromuscular blockade. Look at the compliance. So if the compliance is more than 40, then this is L phenotype. And here you can do prone positioning. Tidal volume can be kept at 8 ml. You should not be going high on PEEP here. But if you have static compliance less than 40, So this is the one with a low compliance. This is the H phenotype. And here tidal volume should be lower to 6 ml per kg. Consider stepwise increase in the PEEP, consider recruitment maneuvers, prone positioning. And if they are refractory, then of course you look at the ECMO. And what are the oxidation targets? SpO2 90 to 94, PO2 about 60, 55 to 80, PCO2 by keeping pH more than 7.3, P-plat less than 30 or 28, so on and so forth. So ECMO is as we have seen, whatever phenotype, if they progress to this kind of a thing, then ECMO is the last resort. So we need to go for prone positioning, neuromuscular blockade, pulmonary vasodilators, high PEEP, recruitment maneuvers whenever the PF ratio is less than 150. And we need to consider ECMO when there is worsening refractory hypoxemia or PF ratio is less than 80 millimeter mercury for more than 6 hours, or PF ratio is less than 50 millimeter mercury for more than 3 hours, or signs of poor perfusion and hypercarbia, that is pH is less than 7.25, PCO2 more than 60 millimeter mercury are present. We also alternatively can consider for ECMO when patients with PF ratio more than 150 millimeter mercury, associated signs of poor tissue perfusion and hypercarbia. So again, in cards, possibly we can look at oxygen therapy plus awake proning, HFNC and IV awake proning. Then we go for intubation, prone ventilation, and ECMO. This could be the escalation matrix here. So in a nutshell, to conclude, there appears to be two distinct phenotypes based on the biomarkers and the association with mortality. Whatever, the ROC curves have been constructed, they show very high accuracy in mortality prediction. And the reactive or the hyperinflammatory phenotype has